Hello, I'm Carolyn Owen. I'm a hematologist in Calgary. This presentation is an update on abstracts presented at ASCO and EHA for CLL and their relevance to the Canadian landscape. These are my disclosures. This work was conducted with the help of Impact Medicom medical writers and with funding from AstraZeneca. Several of us reviewed these abstracts and worked together to create this presentation, which is available at the link that you can see on the slide. So the purpose of the review was to look at the practice-changing presentations related to CLL. Those that we've selected are the updated frontline acalabrutinib study, the comparative studies of second-generation BTK inhibitors versus ibrutinib, and then the frontline fixed duration novel therapy regimen I+B compared against chlorambucil and obinutuzumab. This is just to remind you of the current Health Canada approvals for the different drugs that we'll be discussing. Just because an agent has Health Canada approval doesn't mean that it is funded for that indication in Canada. But we know that zanubrutinib that will be discussed currently only has an indication in Waldenstrom's and mantle cell, although I expect it will get an indication in CLL soon. And even though several of these indications have broadened recently, funding is still really just coming into a place for several of these therapeutic areas. So we wanted to review the important CLL studies that were presented at ASCO or EHA. And the studies are listed here. So the first was this update of the Elevate-TN, which is the study comparing acalabrutinib with or without the antibody obinutuzumab against chlorambucil and obinutuzumab for patients who were not appropriate for fludarabine, so sort of an older population. This reminds you that it was a 1-to-1-to-1 randomization, but unfortunately the study wasn't powered to detect a confident difference between the two acalabrutinib arms, which will prove to probably be of interest in the coming years as we look at that data, because we need to decide what we think about the value of obinutuzumab added to acalabrutinib based on this data. The median age of the patients was 70, so it was fairly reflective of a frontline treatment population who were not fludarabine eligible. Patients with deletion 17p were allowed in, and so there was 14% with that either TP53 mutation or deletion 17p. But otherwise, the population I would say is pretty typical for your frontline CLL patient. We did see the data presented for the primary endpoint of progression-free survival at meetings last year, and this is just follow-up data from continuing to follow the patients. The median follow-up is now about 4 years, and progression-free survival continues to be significantly better or even more of a difference, favoring the acalabrutinib arms over the chemoimmunotherapy arm. The sort of topical discussion really is about the two acalabrutinib curves and whether the relative improvement in PFS noted with the obinutuzumab versus the acala-mono, which is the blue curve here, whether that is clinically significant enough to compensate for the added toxicity, the added cost, the added inconvenience of including that antibody. So overall survival remains not different between the groups at this time, although there's nearly so there's starting to be a bit of a difference between acala plus O versus chlorambucil O, and then response rates are greater with acala O. I'm not really sure anybody cares about response rates or MRD levels with the BTK inhibitor-based study compared against chlorambucil O. One of the important things that we know about BTK inhibitors is that if there's toxicity, patients will often not want to remain on therapy or wish to discontinue. And so the discontinuation rate for adverse events at this point in time is about 13%. The reasons for discontinuation or the common adverse events are the same that we knew of acalabrutinib from previous years. There's been no new sort of side effects or safety signals that were presented from this updated data. So diarrhea and headache are the most common problems that are seen with this drug, headache being quite time limited and common just at the beginning of therapy. The adverse events of clinical interest, we won't spend too much time looking at because I think this is more relevant to the discussion about the head-to-head studies. But again, there was no sort of new signals of interest in relation to cardiac events or bleeding or hypertension with the acalabrutinib in this frontline study. So, I mean, this just continues to show that this is an excellent agent. Whether or not you should be including obinutuzumab is really the big question. I think most people would agree that that's a very unappealing option. And unless we have really confident results that tell us that patients do significantly better with the obinutuzumab, we'll be favoring just using acalabrutinib monotherapy at this time. I think that the other big question is, now that venetoclax and obinutuzumab, which is time limited, is just becoming available in Canada, how do we look at this acalabrutinib frontline data in the setting that we will now be having access to this agent at the same time that we're having access to venetoclax and obinutuzumab, because there's no direct comparison between those two agents or between Ven-O and ibrutinib monotherapy. So I think that people are going to continue to have to make individual patient related decisions in terms of frontline treatment for CLL, but some of our provinces will direct our decisions through funding restrictions in an attempt to keep costs contained, because indefinite BTK inhibitor therapy is going to be expensive, whereas venetoclax and obinutuzumab would obviously be likely more cost effective. And then the additional questions are whether there are patients who would do particularly better with one or other of those therapies. And we don't know without good prospective clinical trials to answer that question. Most people still want to give a BTK inhibitor for patients with TP53 aberrations, but there hasn't even been, confident data in that bad risk subgroup either. So the study that I thought was one of the most interesting presented at these meetings was this ELEVATE-RR, which is the comparative study of acalabrutinib versus ibrutinib in relapsed refractory CLL. Some things to note about this study: it was unblinded, so the patients entered the study knowing that the second generation drug was hopefully going to have less side effects, and they knew which drug they were getting. The primary endpoint was to demonstrate non-inferiority, and so they selected what they hoped was a high-risk population so that they could meet their endpoint sooner, because you need to have events of progressions or deaths if you're going to show a difference or a lack of a difference in progression-free survival. So they selected patients who had deletion 17p or deletion 11q, specifically in the relapse setting. So the study had sort of a higher risk relapse population. And I think the median prior line of therapy was 2. So this is sort of mostly third line patients, but they could be second line or greater. As I mentioned, the primary endpoint was to show a lack of inferiority of progression-free survival by independent review committee assessment. And they have confidently done that with a hazard ratio of 1. Can't get more non-inferior than that. Then the secondary endpoints were the adverse events of interest, really, to try to see if the acalabrutinib was better tolerated than the ibrutinib. And the first of the secondary endpoints that was assessed was atrial fibrillation, atrial flutter, which was significantly less frequent in the acalabrutinib arm. And there were less discontinuations because of that event with acalabrutinib compared to ibrutinib. They then looked at some other secondary endpoints, like grade 3 infection, grade 3 or more infection, or Richter's transformation, and there was no notable difference between the acalabrutinib and the ibrutinib groups for those endpoints. There was also no notable difference in overall survival. So more patients discontinued for adverse events in the ibrutinib group. Remember again that this was an unblinded study, but then that ends up meaning that more patients discontinued for progressive disease in the acalabrutinib arm, because obviously they stayed on therapy longer to get to that sort of time point. These are some other specific percentages for the toxicities that were looked at, with diarrhea being very slightly more frequent in the ibrutinib group, headache being more common in the acalabrutinib. We know that's a very sort of specific side effect for acalabrutinib. Arthralgias looked a bit less with acala. Hypertension looked quite notably less, and we know that that's sort of a link to cardiovascular disease and events, so I think that's of interest. And then bleeding also slightly less. So there were a couple ventricular dysrhythmias on ibrutinib, but none described so far with acalabrutinib. The bleeding rates were slightly less with acalabrutinib, but both drugs cause bleeding. And then there was a couple other comments like pneumonitis, and I'm not too sure how trustworthy that one is. It's not an event we recognize frequently with BTK inhibitors. But the cumulative cumulative incidence of all the sort of AEs of interest and the things that we think of as being reasons for having problems getting patients to continue to take ibrutinib were all less with acalabrutinib. So obviously the author's conclusions were that acalabrutinib was better tolerated and had lower cardiovascular and bleeding complications, and that is important, and that it was equally efficacious. Following that presentation, there was this late breaker presentation of the Alpine study, and the Alpine study was a very similar study, but a bit different in a number of ways, and it was the comparison, again in relapsed refractory disease, of zanubrutinib versus ibrutinib. This one did not specifically target a higher risk population, and the patients were not quite as high risk, so they had a median prior lines of therapy of 1. There was far less deletion 17p because they didn't select for them on the study. And they also had a primary endpoint of, and their primary endpoint was not PFS like we would normally look at, but it was investigator assessed overall response rate in an unblinded study. So you as the investigator and your patient know what drug they're getting. They know that they wanted to get the newer, better drug, and then you assess the response, and that was their primary endpoint. They, interestingly, also defined their primary endpoint of overall response rate as not including partial response with lymphocytosis, even though that is the accepted response definition currently for BTK inhibitors. So their primary endpoint was sort of reached in terms of showing superiority of zanubrutinib over ibrutinib for their investigator-assessed overall response rate of PR and CR. But if you look down at the overall response rate, if they were to have included partial response with lymphocytosis, the difference is much less marked. And remember, it's an investigator-assessed study. Also, this is an interim analysis that only looks at 415, I think, of the 650 patients on the study, and they only have a median follow-up of just over a year. So they presented this data like it was very exciting. They showed a benefit of zanubrutinib over ibrutinib, and then they went on to show PFS and OS curves that similarly seemed to be favoring zanubrutinib over ibrutinib. This is very early data, and I'm not sure how well it has been validated at this such an early time point. There was a few other points of interest. Neutropenia was actually more common with zanubrutinib than ibrutinib. Not that they were really big number differences, but the diarrhea, arthralgias, and muscle spasms that we know are a problem with ibrutinib were more with ibrutinib than zanubrutinib. The big AE of interest of atrial fibrillation was also less common with zanubrutinib than with ibrutinib, but there was no difference in hemorrhage or hypertension. So actually, sort of somewhat less benefit in terms of reduced toxicity in some ways, and yet they're reporting progression-free survival benefit. So I think that we need to just wait a bit for this study, and I think we need to recognize some of its really significant limitations. And comparing the two studies, I think the acalabrutinib study is much better quality study. I'm not saying acalabrutinib is better than zanubrutinib, though. I think that probably the second generation BTK inhibitors are better tolerated than ibrutinib, and that's about all we can say. And I don't really think that I would have a favorite. Obviously, you're going to get used to whatever drug you're using, but at this point in time, I would say that I would favor a second generation BTK inhibitor. I'm not strongly in favor of one over the other, but I have a lot of personal experience with acalabrutinib. It's currently available to me. So those things obviously make it my local preference. Would we be able to extrapolate the data from this study to other situations? So obviously this is a relapsed refractory high-risk population. Could you say that acalabrutinib might be better than ibrutinib in young, fit, unmutated patients who are getting this frontline, or patients without deletion 17p or deletion 11q? And I think we could probably extrapolate pretty broadly to any BTKI indication, at least within CLL. But whether the funding agencies will agree with doing that is sort of to be determined. So again, as I was stating, I don't really think that you can look at the data and suggest that zanubrutinib is in any way better than acalabrutinib, but it does look like both of them are favorable over ibrutinib in terms of reduced toxicities. So the final study to talk about is this phase 3 study, again, a frontline study of fludarabine ineligible patients, comparing chlorambucil obinutuzumab, which is always a standard of care now for these studies, against ibrutinib and venetoclax, so fixed duration novel oral agents. So the patients had a 3-month lead-in of ibrutinib alone, and then they added the venetoclax, and they had 12 more months of the two drugs in combination. So roughly, 15 4-week cycles of the I+D, and then chlorambucil O was for the standard 6 months. The patients could not have a known deletion 17p or TP53 mutation. Like many centers, we don't test for TP53 mutation, so they didn't exclude some patients who might have had those things if they weren't known. The median age was 71. Most patients were quite reflective, I think, again, of this sort of frontline non-fludarabine eligible population. The primary endpoint was IRC-based progression-free survival, and there was a strong superiority of I+D over chlorambucil O. A lot of people have questioned why there's this abrupt drop-off in the chlorambucil O arm, and I think that's because this is an industry-sponsored study meeting the FDA requirements, and they kept doing CT scans at fixed intervals, and that's around the time of one of those forced response assessments. So patients are going to have very minor changes in lymph node size and be called a progression that you wouldn't have detected clinically in routine practice when you're not doing CT scans. Obviously, if PFS is a lot longer, time to next treatment is also a lot longer. And actually, very few patients have been retreated in the I+D arm of this study at this point in time. One of the specific secondary endpoints of the study was MRD assessment and achievement of undetectable MRD, which was significantly higher in the I+D group compared to the chlorambucil O, at about 50% versus 17%. And of those who achieved this undetectable rate, if you followed them out for another 9 months, so 1 year after stopping therapy, most of them maintained that undetectable state in the I+D group at 84.5%, whereas lots of them were losing, of the smaller number who had achieved undetectable with chlorambucil O, many of them were losing that by that 1 year follow-up point. So one of the other points that was highlighted was safety and tolerability and the toxicity information. Unfortunately, there were a few patients who died on the I+D arm that looked to be related to cardiac events from the ibrutinib. And so we already recognize that that's ibrutinib-related risk, but obviously it was not the goal of the study to see patients lost on therapy, and certainly not early on in therapy. Otherwise, though, the toxicities were pretty much as you would expect for each of the individual drugs. There was no new signals for the I+D combination together. Neutropenia was quite common, but yes, you see quite a bit of neutropenia with venetoclax on its own. And so, and the infection rate wasn't significantly higher than what had been seen with VO or some of the ibrutinib frontline studies. So these results are really very favorable in terms of progression-free survival advantage of a fixed duration, all oral, once daily regimen. The rate of toxic deaths in the I+D group is a bit concerning. And again, this is just like the acalabrutinib frontline data, the difficulty in assessing how we place I+D in the current context of Ven-O becoming available. Now, the Ven-O study also lost a few patients at the beginning and didn't have an overall survival advantage at all, with a few treatment-related or on-treatment deaths in the Ven-O arm. And so somewhat we might be able to learn how to give this a bit better, but it's pretty hard to predict for sudden cardiac death. And so I think a lot of people have been looking at this data and saying maybe this I plus V combination would be actually a lot better geared towards a younger patient population. And so this is, I'm going to go very quickly because it's a phase 2 study that's been presented before, but this is that I plus V combination given in the exact same way in a young, fit population. So median age here was 60. They were a variety of different patients, but tended to have higher risk features. This median follow-up of 28 months was the same as on the GLOW study. So this is really just a phase 2, one-arm only study, which is the same combination as the GLOW in younger fit patients. And they focused a lot on undetectable MRD. It looks like the undetectable MRD levels are a lot better in this study, but this is actually best achievement. And in the GLOW study, they're presenting just at a set endpoint. So some of that's a little bit of a false difference, and the undetectable MRD rates are only minimally better in this study than in the GLOW. So response rates are really high. Everybody responded. Most patients completed the study therapy because in the young and fit group, they didn't have a lot of toxicities or drop-offs. And the PFS rates are looking very good with excellent overall survivals, even in the high-risk group with deletion 17p, where we mostly would think of keeping them on BTK inhibitors forever. Most people weren't particularly excited about a time-limited therapy. They mentioned that getting the ibrutinib means that most people end up having low or medium risk of TLS and avoiding hospitalization when they start onto the venetoclax. That's quite expected because we know ibrutinib does a really good job of reducing lymph node size. Again, from a perception of this toxicity, it was really just the normal side effects that we know from the ibrutinib and for the venetoclax. And when it's only for a year, I think patients are much more willing to accept some side effects. There was one sudden cardiac death in this study. So that signal is not completely gone if you're looking at a young and fit population. So these results also support that combination is a very effective one. I kind of think that it'd be nice to be able to offer this to the young, fit, unmutated patients who currently have to go on to a BTK inhibitor and be on it for the rest of their life. I'm sure they would all really relish the idea of a fixed duration therapy for that sort of higher risk, but fit and young and motivated group, for whom in Canada, we don't actually have Ven-O as an option either. So I think that my take homes here, as I mentioned, that ibrutinib venetoclax is a very effective therapy. It is time limited, and that's great. Most people, you shouldn't have to be admitting people for TLS ramp up for the TLS screening when they start venetoclax because they've had ibrutinib for a few months before. I'm not sure if it's going to replace Ven-O by the time it gets its P-coder approval, because we've been using Ven-O for a while, but we'll have to see how it's funded and how broadly it is available to us. Some people are worried about what you do after if you've given both venetoclax and ibrutinib in frontline, but there was a couple patients in the Captivate who were retreated after progression with ibrutinib alone, and they responded. So I don't think you're breeding resistance, or at least we don't have a signal for that right now. Really, I think there's just a number of outstanding questions that remain. So this is just the summary slide of these presentations. I think that we've seen that the second generation BTK inhibitors are equally effective and have less side effects than ibrutinib. The ibrutinib was the BTK of choice for the combination fixed duration study, and that looks like a very effective regimen. It'd be interesting to see if we can see some combinations with second generation BTK inhibitors in the years to come. Thank you for your interest.